Hi everyone, I'm Scharon Cameron. I'm a consultant in sexual and reproductive health here in Edinburgh and chair of the Science and Education Committee. And together with my lovely colleagues, Jack Pearson, Victoria Mail and Alsion Edelman, we're here today for this webinar on COVID-19 and women's health. And you can see the programme after a little brief introduction about how the webinar is going to work today. We're going to move to our two speakers, and then following the two speakers, we're going to have time for questions and answers, and we'll explain how you will ask those questions and how the answers will appear. And then we'll have a little sum up and we'll close. So I'm going to move on to the next slide, which just to remind you about the benefits of being a member of ESC. And I know many of you are, but if you're not, please join. It's a great society and it's only €70 a year. And in addition to all these amazing benefits, you of course get free access to all the webinars, such as the webinar today, and also to our virtual seminar, which will be coming up in May. We'll tell you more about that shortly. And you also get reduced registration fees for our congresses and other events. Next slide. And the aims, of course, of ESC, we are a leading professional society in Europe, and we champion evidence-based education and research, really trying to facilitate people's informed decisions in choosing and using methods of contraception. And the objectives of ESC, for those of you who are not familiar with them, are shown here in the next slide, and really to say that we are the leading professional society in Europe, and together we can become stronger and we can advance sexual and reproductive health throughout Europe and elsewhere. Next slide. And of course, as I've mentioned earlier, please save the date for our next, not webinar, but actually our next seminar, which will be in May on the 12th and the 13th. Fantastic programme, which is in preparation, will be coming out soon. So please put that date in your diary, and that is open for members. Next slide. Is really just also to remind you that another great benefit of ESC membership, and one that you can benefit from today, is our discussion forum, or our doc matter. And if you become a member, you can access doc matter through our ESC community. And if you're already a member and you haven't got access to it, then please email us at this address. And after this webinar, you will also be able to keep up with ongoing discussion about today's webinar and other topical discussions around sexual and reproductive health and around contraception. Next slide. Bit about the practicalities of today. On your Zoom system, you can put your question into the question and answer box by clicking on it. And a selection of those questions will be chosen at the end of the lectures and will be put to the panel. If you see a question that is very similar to what you would like answered, or a question that you would like to see answered, then you can upvote it with the thumbs up sign. And any questions at the end of today that haven't been answered, they'll be put to the panel and they'll be addressed, and they will be posted on the webinar section of our ESC website. And then next is really just to bring us back to today's programme. And our first speaker, I'm delighted to present, and that is Dr. Victoria Mail, who is a reproductive immunologist at Imperial College in London, and who has been undertaking an enormous amount of research in and around the impact of COVID and COVID vaccination in pregnancy. And so we're absolutely delighted that she's agreed to join us today to present on this. So thank you very, very much. It's a real honour for us to have you, Victoria.
Thank you. Thank you. It's nice to be here. And oh no, hang on. My screen sharing is paused. But Try again. Okay, can you see my slides?
Yes, that looks good to me.
Lovely. Okay, well, thank you so much for the invitation to talk here today and for the lovely introduction. My name is Vicky Mail and I'm a senior lecturer in reproductive immunology at Imperial College London. And I think that today between us, Alison and myself are going to cover the whole gamut of female reproductive health and pregnancy. So we're going to start really with fertility, and then pregnancy, which is what comes after, and then kind of, I guess, going back a little bit, and Alison will tell you a lot about the research that she and others have done about the effect of COVID and COVID vaccination on the menstrual cycle. But start with fertility and pregnancy. This is an area in which you might get asked questions, particularly about vaccination, not because there's any reason to believe that vaccination will harm fertility, but rather because a lot of misinformation has circulated on this topic, and that's caused some people to worry. And in response to this public concern, studies have been done, and I'm going to start with this one by Amelia Westlink, because it covers SARS-CoV-2 infection and COVID vaccination, and their effects on chance of conception among more than 2,000 couples who were trying to conceive through intercourse. So if we look down at the bottom panels, which look at the effect of infection, you can see that the infection of the female partner doesn't reduce the chance that the couples will conceive. But in the male partner, actually, there is a slight reduction in the chance of conception for a couple of months. And this is actually in line with what we know about what infection does to sperm count and quality, in that it reduces it for a couple of months. But to be clear, that's a temporary effect. So anyone who catches COVID shouldn't worry that they're permanently less fertile. So moving on now to vaccination, which is shown in the top two panels. And you can see that in both males and females, it makes no difference the chance of conception in the month that they're vaccinated. And this lines up quite nicely, I think, with some of the data that Alison's going to present you about any changes that there might be to menstrual cycles with COVID vaccination. So in addition to this study, which is to my knowledge the only one that's in couples trying to conceive through intercourse, we also have really quite a lot now of studies which look at couples who are trying to conceive using fertility treatments. Now, obviously, these are slightly less representative of the population as a whole, because obviously there's a reason that they're seeking fertility treatment, but they have the advantage that they're really well controlled. Because we're in a clinic, timing things very carefully, we know that everyone's trying in the same way at the same time to conceive. And it also allows us to look separately at the effects on ovarian health and ovulation and the effects on implantation, depending on what kind of fertility treatment the couple is having. And none of these studies found any effect of mRNA COVID vaccination on outcomes in assisted conception settings. So that's reassuring evidence on both infection, for female fertility at least, and vaccination when we're thinking about fertility. But when we start to think about infection, unfortunately, it gets reassuring once you're actually pregnant. So in early pregnancy, I would say that the evidence of the harms of infection is equivocal. There are two large and well-designed studies looking at whether SARS-CoV-2 infection increases the risk of miscarriage. This one, Balachandran, down on the front left, finds among a cohort of about 3,000 people that it does. And this one, Calvert, Calvert's not quite in cutoff, at the front right, cannot find evidence that COVID infection causes an increased risk of miscarriage. And stacked behind them are the smaller and less well-designed studies supporting an increased risk of miscarriage on the left and not supporting it on the right. Now, Calvert was done in a healthcare database looking at everyone in Scotland, so it's very large and hopefully it shouldn't be biased. So if I had to pick one horse to back based on the evidence, I would probably go with Calvert, that's to say no increased risk of miscarriage. But as we're about to discuss, we do have very clear evidence that SARS-CoV-2 infection can cause late pregnancy loss. So part of me thinks that given the equivocal evidence and the fact that we know that it can cause pregnancy loss later in pregnancy, I don't think we can completely dismiss the possibility that there is a problem caused by SARS-CoV-2 infection early in pregnancy, perhaps in some people. So moving on now to the effects of SARS-CoV-2 infection in later pregnancy, and the evidence here is a lot clearer. So from about 28 weeks. And we find that when patients land in intensive care, sometimes in order to give them the best chance of surviving, we need to deliver the baby. And for this reason, we see an increased risk of iatrogenic preterm birth. We also see some evidence of immune activation in the decidua, that's the mucosal lining of the uterus, which could perhaps account for the increased risk of preeclampsia in SARS-CoV-2 infection. And it's not super clear, but some studies have also found an increased risk of spontaneous preterm labour associated with SARS-CoV-2 infection. And this immune activation in the decidua could potentially be feeding into that. Finally, and this was a problem with the Delta variant, and it's something that I think we need to be vigilant about with any future variants. We sometimes see this condition SARS-CoV-2 placentitis, which occurs when the placenta itself gets infected. And it's characterized by macrophage infiltration and fibrin deposition in the intervillous space, and also trophoblast necrosis. And this is really associated with very increased risk of stillbirth. And it's probably the reason that even in the general population of people infected with SARS-CoV-2 in pregnancy, we see about a 2 or 3 times increased risk of stillbirth among those who are currently or recently infected. And finally, we do sometimes see in utero infections, and there have been a handful of papers that might have reported subtle changes to babies' lungs and brains if they've been infected in utero. But a quite large study was recently published on this, showing that actually it looks like these babies are broadly speaking okay. And so something worth keeping an eye on, but hopefully some reassuring evidence there. So COVID is bad news in pregnancy, although it's worth saying that these figures come largely from a time when people were getting their first infections in pregnancy with no protection from a previous infection or vaccination. And that's not the position that most of us are in now. So the risks now are likely to be lower than these ones that we found earlier in the pandemic in the population as a whole. And part of the reason for this, of course, is vaccination. But that then leads us on to a different question. So COVID infection in pregnancy is not safe, but is COVID vaccination safe? And to start with the basic biology of these vaccines, we do know that mRNA vaccines can leave the site of injection. And when they do, they go mostly to the liver. And we've actually known this since the preclinical characterization in 2015. But surprisingly often, people aren't aware of this, which is why I think it's important to be quite explicit and mention it when we're talking about it. And the fact that the vaccines have the potential to leave the site of injection means that they might have the potential to cross the placenta. So studies have actually been done looking to see if babies raise their own IgM response to the vaccines. IgG, of course, crosses the placenta. So if we see IgG in the baby, that doesn't tell us anything, just tells us that mum has raised a good immune response. But IgM doesn't cross the placenta. So if we see IgM in babies, that tells us that the immunogen, whether it's the vaccine or the virus, has crossed the placenta. And none of the studies that have looked at this have been able to find any evidence of IgM in umbilical cord blood following vaccination in pregnancy. And then some studies have gone further and actually looked specifically for evidence of the vaccine in placenta and cord blood, but they can't find it. And there's also no evidence of any pathology of the placenta associated with vaccination. So that all sounds reassuring, but of course we'd really like to know about the outcomes. And we actually have just an unbelievable amount of evidence on that now. So these 9 studies are what we would call registry studies. That's to say they take a cohort of people who get vaccinated during pregnancy and follow them up to find out what happens to them. And then they calculate the rate at which certain events, like say miscarriage or preterm birth, occur, and see if it's different from, usually from historical data, which all of these find that it isn't. But the potential problem with this approach is that there might be other reasons that pregnancy outcomes now would be different from those in the past. The main one, of course, being the pandemic itself, which has made quite an impact on maternity care in some places. So it might be nice to use approaches that have a contemporary control group of unvaccinated people, although of course that has its own problems. People who choose not to get vaccinated might be different from those who choose to get vaccinated in all sorts of ways. But anyway, there are two approaches to this. So these 4 case control studies each take a specific outcome and using national data registries ask, are people who experience the outcome more likely to have been vaccinated than gestationally age-matched people who did not experience the outcome? And using this approach, these studies haven't been able to find any association between vaccination and either miscarriage or stillbirth. These studies take another approach, which is to recruit a cohort of people vaccinated in pregnancy and a cohort that has not been vaccinated. And ideally, they either create pairs of vaccinated and unvaccinated individuals who are matched for various confounding variables, or they control for confounders mathematically. But it's important to note that some of the really big data sets here, like the current iteration of the UK HSA data, just say, well, this is everyone in England and Wales, you know, we're showing you the whole population data, there's no control for it, this is just what's happening. And these studies, they follow up the 2 cohorts to see what outcomes you get. And again, none of these studies are able to find any increased risk of any of these poor pregnancy outcomes that they look at following vaccination. And there are actually so many of these studies now that I have had to fit them across 3 slides. But don't worry if you can't keep up, because if you wave your phone at this QR code, it will take you to an online version of these tables with clickable links to all these studies so that you can go read them yourselves if you would like. Or, if that's all a bit much, I'm quite often asked to deliver this material in 3 minutes flat to busy midwives who need an evidence base to counsel their patients. And for that, I have this slide, which really just summarises what I've already told you. COVID vaccination is safe in pregnancy, but COVID is not. But it does also really give you an impression of just how much data we're making this assertion on. It's now more than 360,000 people vaccinated in pregnancy and followed up informal studies worldwide. Okay, so it's safe, but is it effective? Of course, another important question about vaccination. And the answer to that is yes, COVID vaccination is about as effective during pregnancy as it is in anyone else. The data, that's data I'm showing you now from a systematic review on doses 1 and 2. So that's not so relevant now that most people have had doses 1 and 2, and we'll be moving on to boosters and even second boosters. But we do also have evidence on the effectiveness of boosters in pregnancy. And we find that these also reduce the risk of COVID disease in pregnancy. And that's above and beyond the protection or the risk reduction that we already have from doses 1 and 2. But more than that, when we look at obstetric outcomes, so we're not just looking at COVID disease here, there is some evidence that COVID vaccination reduces the risk of stillbirth. That might make sense, given that we know that SARS-CoV-2 infection can cause stillbirth. But we do also have to consider that people who look after their health in other ways might be more likely to get vaccinated and therefore less likely to have a stillbirth. And even in studies that try really hard to control for this, one of my favourite ways they try to control for it is by looking at people who have had their pertussis vaccination, so they're controlling for it with a different vaccination. Even in those studies, there might be some uncontrolled confounding that exaggerates this effect. But it is also important to say that this recent paper tried to find every report in the literature of a stillbirth that was caused by SARS-CoV-2 placentitis, and not a single one of those cases that are reported in the literature of a stillbirth caused by SARS-CoV-2 infection was in someone who had been vaccinated. Finally, we know antibodies transfer across the placenta during pregnancy, IgG, I mentioned before, and those transfer across the placenta into the baby. So we might expect to see some protection against COVID in babies born following vaccination in pregnancy, like we do for tetanus and whooping cough. And we now have evidence that yes, babies born following vaccination in pregnancy are less likely to become infected with SARS-CoV-2, and they're less likely to be hospitalised with COVID. So we know a lot about this now, and I'll summarise that for you in a moment. But before I do, what's still to find out? Mainly, I think we need to get a better idea of the risks now. And that's partly to do with variants, which keep changing. Although actually there was a recent paper in the Lancet that showed that among the unvaccinated, Omicron continues to be pretty bad news in pregnancy, and basically just as bad news as the original Wuhan strain was. So of course we do have to keep up with any changes caused by any new variants. But mainly, I think that what we need to get a handle on now is that most people have now been vaccinated, boosted, or infected, or some of them all three. What are the risks for them, and how does that change, as we move further away from your most recent booster or perhaps infection? How does it change over time? And what is the differential risk between someone who does or who doesn't choose to get an additional booster in pregnancy over and above the protection they had with them before they became pregnant? Because this is the information that's really relevant to the decisions that people will be making now. But summarise what I've told you. So there's some evidence that COVID infection can temporarily reduce male fertility, but female fertility seems to be unaffected. And COVID vaccination does not impact fertility. COVID in pregnancy increases the risk of stillbirth and preterm birth, but we have very extensive evidence that shows that there's no increased risk of pregnancy problems associated with COVID vaccination, and that vaccination reduces the risk of severe disease and stillbirth, and also provides newborns with some protection against COVID. And I will leave it there.
That's great. Thanks very much, Vicky. Just before we move on to our next speaker, just to remind the audience that we're going to take questions and answers all at the end. So if anybody has any questions for Vicky, if you can put them into the Q&A chat, others can upvote if they feel that they're questions that they would like to be answered. And also, if you have a look in the Q&A chat, there may be some questions that people have already asked regarding availability of the webinar and about attendance certificates and how you can access those. So if you go to the Q&A section, you can find that information there now too. Okay, so now I'm going to pass over to Jack, who's going to introduce our second speaker.
Hi everyone, my name is Jack from Natural Cycles, and today we've got Dr. Alsion Edelman speaking for us. Alison's an obstetrician and gynecologist based at Oregon Health Science University, and Alison has special training in complex family planning. Her interests include family planning, contraception, adolescent gynecology, and international reproductive healthcare and development. So Alison, over to you.
Thanks so much, Jack. I'm just going to share my slides here, and hopefully you guys can all see those. Yeah, great. Well, it's a pleasure to be here all with you. I'm a little bit earlier than you and still getting my caffeine in for the day. So if I have some word finding difficulties, you'll have to excuse me. But I'm just going to start out with talking a little bit about the COVID vaccine, and then also a little bit about COVID infection and menstrual cycles. I do have some disclosures, but specific to COVID and menstrual cycles, that work for myself was funded by the National Institutes of Health, and I will be presenting some of the research that our team has done. And I also want to recognize that actually Jack, Scharon, and Vicky have all been part of my collaborating team, and so really it's an honor to be able to present some of our data today and to have them trust me to present it. So I'm probably speaking to the choir in the fact that periods matter. And I think many of us as gynecologists, if you are gynecologists joining, or primary care specialists, or just individuals who are interested in this topic, know that periods matter. I think the global population of individuals didn't know how much periods mattered to the public until the COVID vaccination really controversy came out, and there were a lot of news reports around this. And I think this is interesting because there's so much literature around periods, the extensive stigma around them, gender discrimination, the existing myths and misinformation that were even existing before we came to this point with COVID vaccination. It is a critical patient key outcome that patients are really interested in. And we can see the rise of femtech like natural cycles and other tracking applications that people want to be able to track their menstrual periods. It helps them with their own health. It helps them have some empowerment and control over their own health. And so really, I think as an integral biological function, I'm not sure why we were caught by surprise by all of this when patients started reporting something happening. And I don't know about you, but in the United States, because we don't really have a public health system, I don't think many of us knew that we had an official tracking system for COVID vaccines or for any vaccines, which might be a little bit different in the UK. With the yellow card reporting system that may be a little bit more advertised. But in the US, I think the COVID vaccination was really the first time we recognized we could report in a massive way to our government that something was happening. And many of you know that I'm telling this narrative, but we all lived through this. So I'm just kind of trying to go back a little bit as this became an issue and was recognized as a problem. And for these reporting systems, they're passive surveillance. They don't ask about menstrual health. And so people have to recognize it's an issue, and then they have to write in something freehand. And then the governments actually have to categorize those things as an issue. And so the write-ins were variable. I missed my period was irregular, I had heavy flow, I had lighter flow. All of those things were reported. And now in retrospect, what's happened is analysis of those databases has shown that there was an overabundance of reports around menstrual health. And I think a lot of the public attention to that allowed people to write in more and pay attention to this. And at this point in time, actually, the UK has recognized that heavy flow may occur post-vaccine, which is interesting because the preponderance of the data from cohort studies has been focused on cycle regularity and not necessarily heavy flow. But the reports from the public have been really focused around heavy flow. And I'll talk a little bit around that mismatch and why we have that. So the other thing that I wanted to talk about is, could we have anticipated this? Is this something that we've seen with other vaccines, or is this brand new and this was a surprise? And what's interesting is, even from 1913, we've had reports of individuals whose menstrual cycles have changed. And that's just telling you kind of the lack of attention that people have had towards this routine biological function that people think that's no big deal that you had a change in your menstrual cycle, but we need to recognize, just like gynecologists do, individuals recognize this as something that's important to them. And so even with typhoid vaccine, we've seen this, rubella vaccination, HPV vaccine, hepatitis vaccine. And what's interesting is we've also seen the level of public concern that's created vaccine hesitancy in countries when HPV rolled out. And there was a huge concern in Japan and public reporting of concerns around menstrual cycles that to this day have created vaccine hesitancy around the HPV vaccine, and actually is leading to statistical calculations that show that that country will probably have increased deaths from cervical cancer because of that vaccine hesitancy. So we've seen this before, but the lack of attention around it did not allow us to create foundational evidence for the public to be able to speak to this, or for clinicians to be able to talk to their patients around the possibility that this might happen. So what do we know now? There's a systematic review that's in preprint that's combined much of the evidence around menstrual cycles and COVID-19 vaccine. And you'll see here that they've found 11 cross-sectional studies. So people reporting that they're having a change, and then 3 cohort studies. But only 2 of those cohort studies have a control group of unvaccinated individuals. Now, menstrual cycles are variable naturally for the majority of individuals. There are some individuals whose menstrual cycles obviously are not as variable because that's just what happens in a population. But we know that menstrual cycles are variable at baseline within a certain kind of subset. If they're clinically outside of that, then we start looking for other abnormalities. But within a normal subset of individuals who menstruate, their menstrual cycles vary a little bit. So to be able to determine if an exposure is causing an issue, we have to have an unvaccinated control group or just a control group. So really only 2 of these studies can actually tell us, is it related to vaccination? And actually the systematic review, again, it's in preprint, but it's missing 2 additional studies that actually also have an unvaccinated control group. And so I thought I'd tell you a little bit about one of those biggest studies, which is one of the studies that we've actually published. So I just wanted to tell you a little bit more about how that study was done and to look at the evidence for it. So this is a study that was a retrospective analysis of prospectively tracked menstrual cycles. So a population interested in tracking their menstrual cycles who did not know a pandemic was going to happen, neither did we, but because of their interest in tracking, we were able to actually use that data to be able to answer a question. Many of these menstrual cycle tracking applications don't ask a lot of questions about demographics that we might want to know about. In particular, in the United States, we're very interested in generalizability to populations across ethnic and racial groups. And that is not something that typically is related to differences in menstrual cycle, but it's important for our populations to know who's represented in the studies. But that's not something that apps ask. So we had to ask our industry collaborators like Natural Cycles, could they ask individuals some extra information so that we could know the population that we were looking at? We had age, we had their menstrual cycle tracking, but we didn't have information about who they were, how they identify, if they identify by gender differences, if they identify also with race, ethnicity. So we asked those questions. The other thing in these applications is that not everybody has to answer everything. They have to track their cycles, but they don't have to answer things like, what is their BMI? Now, what's interesting about Natural Cycles is that individuals who are using that are using it to plan pregnancies or prevent pregnancies, and they cannot be on hormones. And that's the group of individuals that we really wanted to know about because we wanted to identify, is this signal of abnormal menstrual cycles related to the COVID vaccine? And as we know, as individuals who study hormones, that's a different question in individuals that are using hormones or who may be postmenopausal, to be able to tell if this is actually causing an issue in naturally cycling individuals and causing an issue possibly to the hypothalamic pituitary axis that controls menstrual cycles. We have to see if it's happening in this naturally cycling group. So we looked at this group, and I think our original paper in the US cohort made a lot of news, but we have a bigger cohort of a global population that's been published since then, and this is kind of the group that I'm talking about. The other thing that we wanted to look at is, in this group, we needed to have individuals that were having regular cycles before their vaccine, or if you were unvaccinated, over the same time period, so that we could compare, is this variability that normally is occurring happen a little bit more after the vaccination. And so we were looking at the difference between pre and post-vaccination and then comparing it to the unvaccinated group. Okay, so the global cohort, which many of you may not know about, actually has about 20,000 individuals, which is one of the largest cohort studies with a control group that's been published thus far. And you'll see here that in the reported vaccination, which is something that we also asked this population about to report their vaccination dates, you can see that we had about almost 15,000 individuals in that. And in the unvaccinated group, we had about 4,500 individuals. And then you can see, which always happens, things drop off just a little bit in the data that we have for first dose, second dose, and post-vaccine cycle. And that's because we're actively studying this as vaccines were getting rolled out. And we didn't pull the data until we thought the bulk of individuals in the reproductive age have probably gotten vaccinated and then had a post-vaccination cycle. But because we're doing this in real time and waiting for people to get their vaccines and then waiting afterwards, you know, obviously we're missing some individuals who are coming back to get vaccinated and then also get their post-vaccine cycle in there. Just to show you a little bit of information about the geographic representation in this global cohort, you can see that we have very high representation from the UK and Europe and North America, which is both Canada and the US, Australia and New Zealand. And then this other, there's a large population of Brazilians in that portion of the cohort. So this is just a depiction of the main information from this cohort study. The vaccinated group is in green and the unvaccinated group is in pink. And just to walk you through, these are our histograms representing the population. And you can see that there's this slight shift over in the vaccinated group where they have a slightly longer cycle, about less than a day or a day. That also happens in the second vaccine dose. And then you can see it shifts back post-vaccine. And this is statistically significant that we were able to see these shifts. So a slight change, but temporary. Okay. The other thing that I'd like to point out, because this is population-based data, and so we have individuals and clinicians saying, well, I'm hearing reports of more change, more shift. And so we have to, again, point out that these are population data. And so sometimes for population data, it doesn't reflect exactly what an individual might be experiencing. And we see that every day in clinical practice too, where maybe you have data that in general, this is the change that happens, but we know for specific individuals, it might be slightly different. So the other thing that we wanted to look at is, okay, is there a larger group of individuals that is experiencing more of a change? And we did see that in the vaccinated group. And this is the representation of the data in a little bit of a different way, but you can see that both in vaccinated and unvaccinated individuals, so unvaccinated individuals in blue and vaccinated individuals in yellow, that both individuals experienced an 8-day or greater change in cycle length. And we use this category because this is the FIGO definition of a clinically significant change. We know for individuals, a change of less than 8 days might be significant depending on their situation, but this is using the clinical definition. And you can see here in both groups that about 5% had a significant change in their cycle length. But you can see in the vaccinated group that a slightly increased proportion, about 6% versus 5%, actually had an 8-day or greater change in cycle length, which is significant for individuals. The other thing that was a question before, because of this concern about this new vaccine type, mRNA vaccines, do they cause something different than other vaccines? The question before, maybe not now, was, is there a difference in how the cycle length changes depending on the type of COVID vaccine you received? And because we have this global cohort who were reporting what type of vaccine they received, we were able to look at this too. And you can see here, there's a lot of overlap, but you can see here that really this is no difference because they do overlap. And this has a large standard deviation, mostly because this is a smaller group in this inactivated virus group that's represented in the cohort. Now, changing gears just a little bit, I want to move back to that heavier flow or lighter flow and what was experienced and what was reported in the public that got more attention in the official reporting systems than possibly the cycle length change. And this has been a little bit harder to study in the applications of tracking users, and I'll explain why in a second. But what's interesting is there was a large survey that was done by social media that was the experience of individuals across a broad group, and 27,000 individuals who were asked about their menstrual flow post-vaccine. And you can see here that a group of individuals reported no change, about 14%, but you can see not heavier flow, and not heavier flow meant it was lighter or the same. So you'll see that no change group is kind of also represented more in the 44%, but you'll see that a significant portion were reporting this heavier flow. And so we wanted to look at this signal more closely, and this has been harder to do in applications because reporting menstrual flow is not a mandatory input in these cycle tracking applications. It's an extra. People can decide to put it in or not put it in. So at least in our analyses of this, we really had to determine who was interacting with the application before their vaccine and after the vaccine, so we could do a comparison and see if the signal was related to the vaccine. Because again, we know that people fluctuate a little bit, but is it related to the vaccine that they're having this fluctuation? So what are the studies that have a control group that are out there? And you'll see that there are a lot less studies that are looking at this with a control group. Both of them are in preprints and so have not been peer reviewed. And one of them, the second one, Darney et al., is our team's paper on this. So the first study, Trogstad, is focused in Norway. It's about 8,500 individuals who first dose, there's about almost 400, and then second dose 5,000, and they have a very small control group of 88. This is self-reported data, which has a little bit more fluctuation to it. And you'll see here that the relative risk of experiencing heavy bleeding is slightly elevated. And this is the information for receiving a first dose vaccine, but the information is very similar for second dose as well. With our study, again, in preprint, we have about 9,500 individuals, 7,000 were vaccinated, 2,000 unvaccinated. This is based on tracked data with individuals also tracking pre-vaccination and post-vaccination, or if an unvaccinated group, just over the same time period. And you'll see that the number of heavy days, there's no difference in the number of heavy days. And we actually saw this no difference in menses or bleeding days in our other publications, which showed no difference in the length of bleeding days, just the cycle length. And we looked at that in a variety of different ways, and it didn't look any different for individuals who were vaccinated or unvaccinated. So this kind of makes sense. There's no difference in heavy days. However, in the quantity or experience, light flow, heavy flow, no change that happened in each of the individual days, we do see a slightly increased proportion of individuals in the vaccinated group experiencing heavy flow days than in the unvaccinated group. So what's the possible mechanism? Dr. Mail had a really nice editorial in Science that kind of talked through this. And so the possible mechanism for cycle length differences is actually fairly well established for other things that happen, not for COVID vaccine. So for other things that change cycle length, typically you have to have something happen in the follicular or the proliferative phase of the menstrual cycle to then change the cycle length. And that's the time period that you're recruiting a follicle and identifying a dominant follicle. And we see this with other instances of infection or inflammatory events that happen because the reproductive system is not, solo. It's something that crosstalks with other systems of the body. And one of the things that it crosstalks a lot with is the immune system. Now, we don't necessarily know what part of the immune system is crosstalking over with vaccines or in particular with COVID vaccines, but all of this is a temporary thing that happens. Now, what about heavy menstrual bleeding? What's causing that? Well, it could be sometimes if a cycle is off, then sometimes that affects how the flow is. We all have seen that in clinical medicine. But there also may be, again, an immune system reaction because we know that different types of immune cells are important to the kind of process that happens with menstrual cycles and menstrual flow. And so it may be these different types of immune cells and also the cytokines that they release when they're activated that is creating that difference with heavy menstrual bleeding. So these are the two leading hypotheses that folks are currently now studying and ensuring that so that we can have an understanding about why this is happening, which will help us also create that foundational evidence that's important for both clinicians and the public to know. So what about COVID infection? Kind of, if vaccines are causing a change, does COVID infection also cause a change? And this has been a little bit harder to study and get a handle on what's happening here. And that's because we have 4 studies to date that are looking at this, and they're conflicting, and most of them are small. The largest study is of the Nurses' Health Study, which is an ongoing long-term cohort study in the United States of nurses who are reporting on their health. And that study did not show a change related to COVID infection. It did show a change related to vaccine. And so it'll be interesting to see how this pans out. The other thing that we don't know, and for many in reproductive age time periods, the type of kind of magnitude of infection and response is different in younger individuals than older individuals. And so that may also play a role in kind of how severe is your COVID, what was your immunity response when you had the infection. So that may also confound the results that we see too as well. So ongoing studies around this to see if just routine COVID infection impacts menstrual cycles. So what are these take-home messages? Well, menstrual cycle length varies with and without vaccination on a population level. COVID-19 vaccine is associated with about a 1-day increase in cycle length as compared to the unvaccinated. And yeah, some individuals do experience more. And we know this happens from data from population studies when you also are looking at an individual. The changes do look like they resolve quickly next cycle post-vaccine, but we do know, just like for anything that throws cycle length off, that some individuals, it takes a little bit longer. They're a little bit more sensitive to getting back on track. We also know that the type of COVID-19 vaccine does not appear to change, the cycle length information that we're seeing. The menses length data, which I talked about, like how long is bleeding happening for at a population level, we haven't seen a change with that. It does look like the data is leaning towards that the COVID-19 vaccine is associated with heavier flow. We're definitely seeing that in signals that are patient reporting, but in studies where we have a vaccinated and an unvaccinated control group where we can really hone down if that signal is due to the COVID vaccine is still emerging. And then COVID-19 infection and menstrual changes, the data is a bit conflicting right now. And really, I just want to point out that this evidence is all limited to individuals who are cycling regularly before vaccine. So we have different groups that we know that have different inflammatory or gynecology issues or postmenopausal that we don't have extensive data yet on. Of course, this work doesn't happen in a vacuum, and because I presented some of our work today, I just wanted to recognize that it was funded by the NIH and my team. The data that we presented here was with our industry collaborators, Natural Cycles and Jack Pearson's team, and we are doing some future work with Clue, but that has yet to be published. So I'll end there, and I think we have some time for questions.
Excellent, Alison. Thanks very much. So I can see some questions have been coming in. Please feel free to keep dropping your questions into the Q&A box down at the bottom there. So I guess the first one here is, do you still recommend to vaccinate patients during pregnancy, knowing that the vaccine might not be as effective to the new variants, and at what term? So Vicky, do you want to speak to that one first?
So I'll tell you about our advice here in the UK, and I know that it's really similar to the advice in many European countries if some of you are tuning in from elsewhere. And I think it's also very similar to the advice in the United States. And that is that boosters now, well, if you haven't been vaccinated at all and you're pregnant, we definitely recommend that you go ahead and get that taken care of. Boosters, we're now offering the bivalent booster, so that's half with the original Wuhan strain and half it's a mixture of an Omicron strain, and that does actually seem to offer some quite good protection against Omicron, and actually even the old boosters offer quite good protection in the short term. And so our advice here in the UK is that based on the fact that we know that COVID is bad in pregnancy and that vaccination can help, if you are pregnant, you will be offered a booster. And that's really exactly the same way that we're treating flu boosters. So for, let's see, since 2010, everyone who was pregnant would have been offered a flu booster in the autumn. And so we now have a similar way of approaching COVID boosters. You get a COVID booster offered to you in the autumn. So in line with what the Royal College of Obs and Gynae recommends, and in line with what the NHS recommends, yeah, I think that's good advice. So we continue to recommend that here in the UK and in many other European countries. And maybe Alison can talk to the precise recommendations in the USA if anyone's tuning in from there.
Yeah, the US has exactly the same recommendation that we're recommending those vaccines in pregnancy as well. And so if you haven't been originally vaccinated, to go ahead and do that. And then if you haven't received your booster, to go ahead and do that too. And that was combined with the flu vaccination, which we always had recommended in the fall, or actually as the flu has extended out into the spring for us. And so we oftentimes are vaccinating for flu almost for the entire year, it seems like.
Cool. And then the next question I've got here, it's actually asking Vicky, but I think it actually might be quite applicable to me, Natural Cycles, and slightly to Alison as well. So it's asking, addressing the issue of privacy and informed consent. Did the Natural Cycles app users give their consent to be included in the data collection? So first of all, when users subscribe to Natural Cycles, they're asked whether they'd like their anonymized data to be used in research, and that's what we call a science consent. So that's the first kind of consent. And then additionally, for Alison's research, we were actually sending messages to users asking them about their vaccination status, and we actually obtained a consent for this as well, which was reviewed by an ethics committee too. So two types of consent there, and we only use users' data if they've agreed for it to be used in research. Excellent.
If I could, just come in there, Jack, I think that this is a really nice example of where we had a problem, during COVID, a question, a concern that was really of importance to women, and where we, and where the team were able to use data from Natural Cycles users to help address it in a scientifically robust way, because these were cycles that were charted prospectively. So I think it was a really lovely example. And I don't know, Alison, if you've been aware clinically of any other concerns that, you know, patients may be bringing about vaccination and their gynecological well-being or fertility.
Yeah, just to represent, it was fortuitous for us when this started happening in January 2021. For the US, we started in healthcare providers rolling out vaccine in November, December 2020. Oh my God, that was so fast. So we started hearing about this in January and February of 2021. We had a call out maybe in March for funding that the NIH put a call out because they were seeing reports. And when we contacted a couple of the tracking applications who have been wonderful to work with, and Jack's team, it was interesting because the public had already been reporting to them because they have this dialogue with their users that they can actively report in what they were experiencing. And because they had already been reporting in, Natural Cycles had already put in place, hey, do you want to log your vaccine to see if this is happening for you, to empower yourself to see what changes were happening. So they were really primed very well for us to partner with them for research. And actually they were very, Jack will be like, I don't know if we'll ever do this again, but they were very kind in saying that, even if I didn't get the grant monies to do this, that it was so important to the population that they were willing to work with us to get the data out there on this. And because they had that scientific consent in place for individuals, and then were consenting as we were asking some additional information, and then we were able to get the regulatory support for that. So I think in regard to menstrual cycle, I think we've heard all sorts of concerns around that, and that's really where the science has focused. But for menstrual cycles, we've seen no change, longer, missed cycles, heavier bleeding, lighter bleeding, concerns about fertility, concerns about pregnancy. And I think because of that, the public has really driven the science around this, which has been super helpful because we can identify something that's important. And then because of at least with the tracking applications, we've been able to answer the concerns from the public. And I think what's hard with population studies is that may not be exactly what the individual themselves experience. So we have gotten feedback around, well, that wasn't my experience. And we should totally recognize that different people have variable experiences, but we can see on a population level kind of what we can put as a foundation, and then we can talk to individuals around that. The one other thing I want to mention is because the menstrual cycle data was a small shift that we saw at the population, now what we're seeing is people saying, at least not the public, but a lot of science folks are kind of saying, well, that's not a big deal. Who cares about that? And I keep on reminding them that a lot of people menstruate. We do it a lot of the time for a lot of portion of our life. And if something controversial happened to them, of something that was just routine, that they just relied upon, even if it was a small change, it would be concerning to them. So for instance, what if you just couldn't see well for 3 or 4 days? What if you couldn't hear well? What if you couldn't taste at all? Those are things that, we've heard. What if you had a headache for a couple days, or for individuals that don't experience menstruation, what if they couldn't pee straight for a couple days, or they couldn't, ejaculate? I think those are things that, when they're a small change, but we experience them and we know our personal kind of experience with them, I think it's really undermining to the population not to recognize that they experienced that change, that now we can say it looks like it is due to the COVID-19 vaccine, but for the majority of people, it gets back on track right away. And if they have other concerns about that skipping, that, we can look into that for them, because each situation is a little bit different. Like maybe they were trying for pregnancy and this might be a pregnancy. Maybe they weren't trying for pregnancy. Maybe they don't want to be pregnant. Maybe they're traveling. So I think that's where that small change sometimes gets undermined now that we have an answer when it shouldn't be.
Lovely, Alison. That was a great explanation. I'm going to keep going through the questions because we've got some coming in. So got one here. Are there studies that relate to cycle length or flow to lockdown, or changes in habits related to stress? So as I'm speaking, I know of one which was conducted on natural cycles data that found that there was very little change from sort of pre-pandemic to during the pandemic stress on menstrual cycles. I will share the link for that paper in the chat there. You have to remember this was done on natural cycles users, and there are specific cohorts, so it's not necessarily applicable to the general population. Alison, Vicky, I don't know if you had any that came to mind there.
Yeah, there's another paper too as well that showed maybe a slight change. I think what's important in our data is, again, we have that control group over the same time period. So we're having people in the pandemic over the same time period, and we're still seeing an exposure causing something different. So that's where that control group helps you. And also we know that in a population level, it has to be a pretty significant stressor to cause a shift in cycle length. So war, famine, really significant changes in weight. But we know for individuals can be more sensitive to some stressors. Some people report, I had that test that I was really stressed about, or I had a really stressful week at work, or I traveled. So we know that there are individuals that are stress sensitive, and Vicky probably has a comment about this too.
Yeah, I mean, so I can't reel them off, but I think there are definitely, apart from the natural cycle study, which didn't show a difference, there are definitely 6 or 7 which take quite a different study approach, in that they ask people about their experiences of being stressed and how that changed the menstrual cycle, specifically in the context of the pandemic. And what I think is really interesting is that all of those studies do find an effect of pandemic stress of the menstrual cycle, but they're going to be biased by people's expectations. But in some ways, they do have a bit of a strength over, the more big data approach, in that the big data approach kind of takes the view that, like, this wasn't the pandemic, this was the pandemic. But stress in the pandemic varied enormously, and it varied for different people at different times. Like for me, the most incredibly stressful part of the pandemic might have been completely different from someone else's stressful part of the pandemic, depending on, your homeschooling situation, your job situation, were you a frontline healthcare worker, were you experiencing a bereavement at a particular time? So some of these other study approaches do actually manage to say to people like, okay, thinking of the most stressful time in the pandemic, we don't care when it was, but thinking of them, can you tell us how stressed you were using scales that for some of these studies are quite well validated, and for some of them are less well validated? And how did it change the menstrual cycle? Some of them did ask for their participants to have some kind of record of their menstrual cycle to try and take away that fact that you might have a kind of recall bias. So I think it's quite a tricky one, actually, because I really like the natural cycles /app tracking approach, because you've just got such a lot of such strong data from people who weren't expecting it to be used to ask the question that you're using it to ask, and that removes so many sources of bias. But I think it does sometimes cause us to miss a few bits and bobs, and I think we can maybe pick those up in those other surveys. And I think it would be lovely to kind of try and do something really, really one day properly formal to really figure this out, but maybe that's something for the future.
Probably this is for you, Alison. Melanie Gold has put in a couple of questions. One is around, were there any differences observed between adolescents, younger women and women of older reproductive age who were still cycling?
because they have to give consent and use of the apps, it's a particular age group. And so we don't have individuals that are in the younger kind of adolescent cohort. And so for that group, there is a researcher who is part of the NIH 5 teams that were funded that specifically looked at adolescents and hasn't come out with that data yet. It also is a little bit harder in that group because we expect some cycle irregularity depending on where the adolescent is in their maturity of their HPO access. So we have yet to see kind of great data around adolescents and their experience, and even in just reports, just because of how studies are done and populations, and that it's a little bit harder to get consent for individuals that are under 18. We have a grant in right now that we hope will get funded, that we can look at that adolescent group a little bit more closely. But I imagine because they have more variability that they might have more variability with having vaccine, but we don't know that. I don't know if Vicky, if you've seen anything, or Scharon.
Yeah, so there's one study that's quite recently been published, and it's interesting because I think the first author is Noel Trogstad, the same as the first author of the Norwegian preprint, which is still a preprint, but this one's been published, and they take a really different approach here. So the ones that we're looking at that you talked about, Alison, is the young adult study, and so they're all young adults. But Norway for many, many years has been running kind of like one of these studies that a lot of countries have, and we have it here in the UK too, where you take a cohort of babies when they're born and their parents, and you study the babies and the parents as they get older. And they took advantage of that to basically look at girls, I think 12 to 15, and they asked, and so this cohort had already been recruited like 15 years ago. So we hopefully don't have too much in the way of recruitment bias there. And also they're very, very confident and competent study participants because they've been studied for the last 15 years. And what they did was they asked the mothers of the girls what the girls' experiences were. And they were actually able to find something not dissimilar to what they found in the adults, which to me is a tiny bit surprising because, as you say, Alison, like it's kind of variable anyway when you're in that age group. But in terms of published evidence, I think it's the best that we have so far that specifically looks at teenagers, and it suggests that the experience of teenagers is similar to that of adults, which in many ways probably wouldn't be that surprising.
Fabulous. And then I've got a bit of a longer question here, which I'll, because we've got time. So the vertical transmission of SARS-CoV-2 seems debatable. No clear conclusion can be drawn so far. So what do you think about the possibility of SARS-CoV-2 vertical transmission? Do you think the gestational infection could affect the immune functions of the placenta and therefore affect the fetus health indirectly, even though no virus was detected in placental tissue? Alison, any thoughts?
That's all Vicky.
Oh, I'm sorry.
Yeah, so let's break that down. Let's first of all ask the question, do we see vertical transmission of SARS-CoV-2? And actually, I think that there is reasonably good evidence that we can do. It's very clear that it can infect the placenta sometimes. And we do have evidence sometimes of IgM being raised to SARS-CoV-2, not just spike, but also nucleic acid. And we see that in cord blood when babies are born. So that tells us that the baby has been exposed to the antigen. So I think, there is vertical transmission. That is sometimes a thing that can happen. Can it affect the immune system of the babies? I have not seen anything that zooms in specifically on the babies who have, we think that they've had a vertical infection because we've seen IgM in them, and then has looked at immune function in those babies. But there has been a paper from Nadia Gomez-Lopez's lab in the United States that looked at a whole big cohort of babies whose mums were infected or weren't infected with SARS-CoV-2 in pregnancy. And that paper found that there were differences in the mother's immune responses, not surprisingly, because you've got COVID, And there were differences in the immune responses, potentially even at the decidua, so the lining of the uterus, which again is maybe not that surprising because, you know, you've got a big immune response going on in your whole body. But they looked at cord blood of the babies and they couldn't find any immune differences in the cord blood, even though they used, you know, quite sophisticated methods that could find quite small differences. Now, important to say that that cohort of babies, in fact, I think they even showed that in that cohort of babies, none of them had vertical transmission. So this is in a cohort where the babies certainly didn't have confirmed vertical transmission, and if I'm remembering the paper correctly, actually had confirmed not vertical transmission. But these babies were fine from an immunological point of view. And we have, as I've mentioned, seen, you know, papers here and there where they're sort of like, oh, here's 6 babies where we know there was vertical transmission, and now we're going to take a look at the development of their lungs, and they seem a little bit smaller than we would expect. And there was a paper that did something similar with brains. But most of the papers that follow up babies after they've been born, if their mothers were infected with SARS-CoV-2 in pregnancy, they do seem to be fine. So, you know, I don't wish to cause panic on this. I think it's reasonably reassuring. My worry really is more the obstetric outcomes that can be associated with SARS-CoV-2 in pregnancy. So, you know, the increased risk of stillbirth and the increased risk that you'll have a preterm birth, which of course can have a really, really long-term impact on your baby, because preterm birth does increase the risk that you'll have a disability that may go with you for life.
Excellent, Victoria, thank you. And then this is one that I actually wrote down, and I think we might have touched on it, but how much is known about the impact of other vaccine on menstrual cycle changes? Just because I know that when we started our research together, one of the things that came up was, oh, the flu vaccine, we've been having that for years and we've never really thought about how it affects cycles. So I guess one of my questions as well on top of this was, what research do you see being done on the future on other vaccines? Do we need to go back and look at other vaccines and study their effects and things like that? Alison, do you want to speak to that first?
Yeah, no, I mean, you know, I think we've seen this signal before in other vaccines, but it was just kind of ignored, except for the Japanese example that I talked about. So it's been reported with, you know, in the 1913 with typhoid vaccine, rubella initial vaccination, they saw like more symptoms associated with folks depending on what phase of the menstrual cycle that they were in. So, and we know that immune response varies depending on where you are in the menstrual cycle. So that's interesting. I mean, maybe you get a better immune response if you're vaccinated at different times in the immune cycle, or if you have different kind of estrogen, not estrogen, we know as people age, they have different responses to vaccines. So there are so many interesting questions around vaccination and possibly sex biological differences in immune response. But, you know, in terms of the Japan HPV experience, and we may have somebody on from Japan from there with HPV, they had a large population of individuals reporting changes across a variety of things, but a lot in the menstrual cycle category. And what happened was that as they studied that pretty closely, they came down to kind of showing that most of the things weren't associated with vaccine, except for the menstrual cycle changes, which they just kind of chalked up were to, okay, the population that's getting the HPV vaccine is an adolescent population who has more variability anyway, which I think, you know, in retrospect is not really probably the tactic that should have happened with that, because not only do they continue to have issues with HPV acceptability, but that's also reflected in some other countries' rollout of HPV vaccine too as well. And again, what's difficult about menstrual cycles and studying menstrual cycles and being where we are now versus then is reporting menstrual cycles, because they have some variability to them. If it's a small signal or even a medium signal, it's hard to see that with self-report that it's due to the exposure, and it's not just due to the inherent variability of the menstrual cycle. So we are at an unusual time period where, number one, we have individuals tracking by gold standard tracking in electronic diaries, that we have an interest of the population to do that. And we have a mass vaccine rollout in everyone across the globe. And so without that situation, we may not have been able to see kind of at the level that we're seeing and the data that we're seeing. And so we had the unprecedented time period, unfortunate for the pandemic, but fortunate to be able to actually look at this in a way that actually gives us data with a control group to be able to link it to the exposure, because given the variability in menstrual cycles, it is hard to do that. I think for future vaccine trials, I think the public has spoken in that people want to know and people have always wanted to know how this affects reproduction, issues of reproduction. It's just menstrual cycles were kind of just pushed aside. And, there's a lot of things that people study in vaccines. And I think if this is a side effect of a vaccine, they now need to include it in vaccine trials because it's important to that particular population of users who get vaccines, just like headaches, just like fevers. And so we need to track that now. But Vicky probably has a response to that.
Yeah,
too.
I mean, couldn't agree more with you, Alison. And what's great about trials is that, you've obviously got a control group who don't even know that they haven't had the vaccine. And that really makes your data very clean, even if you're not going to go as far as asking them to track their menstrual cycle. You're just going to ask them a really simple question like, did you notice that after you had your injection of whatever it happened to be, you don't know, was your period heavier, lighter, the same? Was it earlier, later, the same? Like just those two simple questions when you've got a really solid control group will get you a long way. But I actually think that, we should, if people are still excited enough about it to give people like Alison money for it, I think it would be really, really worthwhile to actually find out if this is something that happens with the flu vaccine, which we could definitely do because healthcare workers every year, will be getting an autumn flu vaccine. And I just think that would put us in a better position to contextualize this in future, because right now we have, this really strong data on COVID vaccination. And we have the data that shows that it doesn't seem to matter the vaccine platform, which suggests to me that it probably does happen across all vaccines. But I think it would be really, really useful if we were able to say like, oh yeah, and we've now looked at flu vaccination and it's very similar. I went, hey, we recruited these people who were coming to the clinic to get a yellow fever vaccine because they were about to go traveling, and we see something really similar. I think that would really help us to contextualize it a bit more. And then I guess what's also interesting to me is a more kind of very squishy end of science sometimes, is to work out what the mechanism is. And I think that one of the ways to do that will be to start looking at people using oral contraception in more detail than we have been able to before. And, then potentially start taking some biological measurements as well as these quite straightforward, you report your period and we use the data. It would have to be smaller cohorts, but I think we now have the justification to do that. And that would be really great to do. And I just think that this is very basic research, regardless of whether anyone's interested in it or not, that is the kind of thing that in the future might turn out to be absolutely invaluable, and we'll be glad that we did it.
And I guess that partly answers or partly speaks to the question that's raised by Raymond Lee, which is that wonderful. He says, wonderful talks. What's the likely biological reason to explain the menstrual cycle disturbance, and for those with menstrual cycle disturbance, over how many cycles? So I guess, as you've said, Vicky, a study that looks at bleeding problems in individuals with inhibition of ovulation through contraception might help address how much of it is ovarian, higher, or endometrial.
I think it's really difficult, this question of what's causing potentially the heavier bleeding, because, I've suggested it myself, but I'm not particularly confident about it. The reason that I think that there's potential for the heavier bleeding to be to do with, what's going on in the endometrium is just because the observation from the Lee et al. Enormous survey, which is that you're more likely to experience it if you're older, which potentially suggests, a tissue repair / wound healing phenomenon, and that would be to do with what's going on in the endometrium. Actually, we start to repair the wounds of the endometrium even while we're still bleeding during menstruation. But yeah, I also think it could definitely be something that, like what Alison suggested, where, the length of the cycle may in turn affect flow. It occurs to me that this is the sort of thing that you could actually look at with the data, the natural cycles data, if there's an association between the two. I don't know if you ever have.
Yeah, it's such an interesting question around this. And I think the other thing that I have questions, I mean, we know that the immune system crosstalks with the reproductive system, and that, you know, with vaccine, you know, you have your innate and your acquired immunity, and there's different cytokines that activate during those time periods, and the immune cells function differently. And so it's fascinating at a more micro level, kind of what is happening. And then over a cycle, if you're getting your vaccine in follicular phase, I believe, although Vicky's going to know this better, that, you know, your acquired immunity is starting to kind of kick in towards when you would have your menstrual period. So, you know, there may be two different mechanisms depending on kind of your immune system response. And when you get your vaccine, that might be triggering the heavy menstrual bleeding. But again, that's a temporary kind of response that kind of happens. So I don't know, Vicky, if you have anything about innate versus acquired immunity. That's interesting to me.
I instinctively feel that it probably is mediated by the innate immune response, particularly because pretty much everything that's happening, well, this is me thinking as someone who works in the endometrium, but pretty much everything that's happening in the endometrium is innate. We have very little in the way of acquired immunity in the endometrium, although we can, if we need to, like we get an infection there. But yeah, I think it's a really good point that you make, that actually if the timing, and we haven't actually spoken about this yet, but if the timing is such that it's more likely to happen if you get vaccinated in the follicular phase, then yeah, is it that it's happening and the innate response is affecting ovulation, and that's what's, or follicle recruitment, or, you know, some of those things, and that's what's kicking on to cycle length, or is it actually happening in the adaptive immune response? And actually, I think both of those are reasonable hypotheses, except I suppose that most of what's going on with the adaptive immune response is quite localized to the lymph nodes. So I still, if you made me back a horse, would back the innate immune response. But I'm an innate immunologist, so maybe that's what you'd expect me to say.
Excellent. So we've got around 4 minutes left before Scharon closes things off. Just to, if there are any questions that we don't manage to answer, they will follow up with those, and they'll be posted on the ESC website with their answer as well. So we've got Anonymous here. Were irregular mid-cycle bleeds common regarding COVID infection in the natural cycle data? Alison?
Yeah, this is where it's a great question. This is where the tracking data doesn't help us as much, because logging period or spotting episodes is not a mandatory variable. So people might do it or might not do it. And then we don't know what they did before or after. And if they didn't log anything before, it's because they didn't have it, or if they just didn't log it. So in kind of retrospectively looking back at the prospective data, it's very hard to answer that question in the data set that we have. I do know in public reports of this that people did report this. So, you know, we are seeing that in the reports, and the signals that we see in the reports are seeming to, at least regarding menstrual cycles, that we're able to show that that is related to vaccine. So, but we just can't see that in the natural cycles data.
It's also worth saying that, of course, we're all super into menstrual cycles, but one really important thing that we haven't talked about here is postmenopausal bleeding. And that's, you know, much harder to get at, because no one's sitting there with an app logging their postmenopausal bleeding, because obviously every day you'll be like, no, it's a normal day for me. And the signal you'll get is people going to their doctors. And that's definitely something that I think it would be really good to get at properly, because for that population, that's a real worry.
Well, I think that this is bringing the webinar now to a close. I can see that there's still loads of questions in the chat, so we'll have a look at those and they'll be answered, and it'll be on the website. You can also continue the discussion on Doc Matter. I'd like to say a massive thank you to Alison and to Vicky for some fascinating presentations and great discussions, and a massive thank you to my co-chair Jack, and also to Natural Cycles, because they have generously sponsored this webinar, unrestricted educational grant. And thank you to all of you who have participated. It's been really great questions, great discussions, and let's continue the discussion afterwards, as I said, on Doc Matter. And please don't forget, if you're not a member, join ESC, and look forward to seeing you at our next webinar, and definitely in May at our seminar. Okay, bye from me.